Hi everyone, this is Jen Sibley presenting on appendicitis this week. With appendicitis in children, this is the most common condition requiring surgery. Early diagnosis is critical for a positive outcome, but diagnosis in young children is often difficult since the presentation may be nonspecific, the child may be preverbal or apprehensive and uncooperative during the exam. To complicate matters even further, although classic patterns of symptoms may occur in school age and adolescent children, they may not be present at all in children under the age of 5, making the abdominal exam a critical part of the patient's workup. As a quick refresher of the anatomy, the appendix is located in the right lower quadrant of the abdomen in most children who do not have other conditions such as situs inversus. The pathophysiology of appendicitis is that it is most commonly caused by obstruction of the appendiceal lumen, secondary to fecal matter, undigested food, other foreign material, inflammation of the lining of the appendix, or an actual twist in the organ itself. Inflammation then begins, leading to bacterial overgrowth and breakdown of the mucosal barrier, leading to bacterial invasion of the wall, inflammation, ischemia, gangrene, and eventually perforation and peritonitis. The epidemiology of appendicitis in children includes the fact that it is diagnosed in 1 to 8% of children who are evaluated urgently for abdominal pain. It most commonly occurs during the second decade of life, and it occurs more frequently in boys than girls. Clinical manifestations in children include anorexia, periumbilical pain that occurs early, migration of pain to the right lower quadrant within 24 hours of the onset of symptoms, vomiting after the onset of pain, fever in 24 to 48 hours after the onset of symptoms, and right lower quadrant tenderness. Other manifestations include symptoms of localized or generalized peritoneal irritation, such as involuntary guarding with abdominal palpation, a positive Rovsing sign, obturator sign, ileopsis sign, and rebound tenderness. And you can also have the child cough or hop, because if they are having discomfort with either of these, it's a positive sign. There are several examples of scoring systems that can be used in the workup of a child presenting with abdominal pain in order to assist the examiner in ruling in or out the diagnosis of appendicitis. This is one example. There is also another example known as the Alvarado system. However, there is limited evidence showing which is better. So let's look at a case now. You have a 10-year-old presenting to your outpatient clinic with the chief complaint of abdominal pain and vomiting since midnight. Upon entering the room, the mom tells you the patient now feels warm. You see his vital signs are a temp of 101, heart rate 115, and he is lying on the exam table on his side holding his abdomen. For the HOPI, you find out the patient has been complaining of a bellyache since dinner last night and did not eat. Mom thought he was constipated and told him to try sitting on the toilet for a few minutes. The patient tried but did not have a bowel movement. He went to bed without eating anything and then woke up at midnight and began with vomiting and still complaining of abdominal pain. Since then, the patient has only tolerated small sips of water and has vomited 4 times since midnight. It is now 8:30 a.m. The emesis was clear with old digested food chunks in it, but the most recent had green tinge. Mom did not give him any medications to help with the nausea or vomiting. Other symptoms include lethargy, new onset fever this morning, and diaphoresis. The patient rates his abdominal pain as an 8 out of 10 on the FACES pain scale, describing the pain as beginning originally as a strong ache, but now it is more intense and constant. His last bowel movement was yesterday morning and was normal soft brown. The patient's past medical history includes no hospitalizations or surgeries or chronic illnesses, no allergies or medications. His immunizations are up to date. Both parents are healthy, and he has an 8-year-old sister who is healthy. He is a 5th grader, a good student, lives with mom, dad, and sister, has 1 dog at home, and no other pets. The review system reveals that the patient has no history of rashes, runny nose, cough, ear pain, sinus pain, or sore throat, or swollen glands, no shortness of breath or wheezing, no cardiac problems or chest pain. He has not had any constipation or urinary retention. He last voided very concentrated urine this morning. The physical exam findings are noted on this slide. Feel free to pause it so that you have enough time to read through the findings.
Created using Powtoon.